Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 3, invasive hemodynamic monitoring, which deals with central venous pressure. So, as with previous courses, these are intended for nurses and other healthcare professionals who may be caring for patients that require central venous pressure monitoring. And this workshop, or Learn Shop, covers the fundamentals. So what are your learning objectives? Well, for this session, we're going to do a pre-knowledge review, as we always do. Look at the indications, components, some of the normal CVP waveforms, and some of the anomalous CVP waveforms, and what nursing considerations, or considerations that you should think about when caring for a patient with a central venous pressure. So, the pre-Learn Shop knowledge review is as follows. Which of the following pertain to a central venous catheter? A, it can be inserted into a subclavian artery, it can be inserted into a jugular vein, it could be inserted into a capillary, or is it all of the above? The correct answer is, it can be inserted into a jugular vein. Question 2. CVP, it's an abbreviation that relates to which of the following? A, signifies central venous blood pressure, is normally 0 to 6 millimeters of mercury, provides data about blood volume, or is it all of the above? The correct answer is, it's all of the above. Okay, question 3. What are some of the complications that could occur if someone has a central venous catheter? It could include which of the following? Infection, air embolism, cardiac dysrhythmias, or all of the above? The correct answer is all of the above. What about components of a flush system? They should include which of the following, which we've covered previously. A pressure bag. B, normal saline solution, sterile of course. A flush valve in the transducer, or all of the above? The correct answer is all of the above. Question 5. Which of the following are true of transducers that are used for central venous pressure monitoring? A, they've got to be aligned to the phlebostatic axis, they've got to be zeroed every day or as required, must be primed to remove air, or are all the above true? The correct answer is all the above are true. Question 6. A CVP is usually synonymous with which of the following parameters? An arterial blood pressure, the left atrial pressure, a jugular venous pressure, or the right atrial pressure? The correct answer is the right atrial pressure. 7. Overdamping of the pressure transducer usually denotes which of the following situations? A faulty transducer, a small sluggish waveform, C, incorrect data, D, all of the above. The correct answer is all of the above. Question 8. Which of the following may assist in the recognition of a cardiac tamponade? An elevated CVP, a low CVP, a fluctuating CVP? Well, a CVP really can't assist you to diagnose or recognise a cardiac tamponade. What's the correct answer? The correct answer is an elevated CVP. So now let's look. What is central venous pressure monitoring? Well, central venous pressure monitoring is monitoring the blood pressure via a catheter placed into a central vein so that the actual pressure in the vein or right atrium can be measured. This provides a continuous measurement of the mean central being close to the heart, venous blood pressure, CVP. What are some of the indications for central venous pressure monitoring? Well, first of all, volume monitoring or assessment, circulating blood volume, fluid management and resuscitation with fluid, Hypertonic solutions or medications that are caustic, such as vasopressors like epinephrine, dopamine, norepinephrine. It can be used to assess right atrial pressures, and it's always used in critically ill patients. So, central venous pressure is then a form of invasive blood pressure monitoring and is done through the cannulation of a central vein like the superior vena cava, jugular vein, which we'll be discussing shortly. This form of monitoring is commonly utilised in the management of critically ill and perioperative patients. So what are some of the potential insertion sites? And potential insertion sites can be the jugular vein, subclavian vein, the antecubital vein, basilic, cephalic and femoral vein. But the most common site of cannulation are typically the jugular and subclavian veins. The jugular vein, the subclavian vein are the most common. So what are some of the required components, which we've discussed previously? They consist of a pressure bag, a flush system, the transducer, the manifold for the transducer, the central venous catheter itself, and rigid inflexible tubing, the hemodynamic monitor, and most important, the competent nurses. The pressure bag, it maintains a constant pressure of 300 millimeters of mercury, and the objective is to infuse sterile normal saline at approximately 3 mL an hour to prevent blood from clotting in the central venous catheter due to a slow, continuous infusion of fluid into the catheter. The flush system. Well, this is used for an indwelling central venous catheter for a continuous flush to keep the catheter conduit, passageway, lumen open. Intermittent manual flushing is unacceptable because of the danger of dislodging small emboli directly into the heart and the threat of bacterial contamination and possibly of infusing an unwanted amount of fluid. The transducer. Well, we've mentioned this previously as well. The transducer changes a physiological signal into a recognisable pressure waveform. Therefore, it provides continuous measurement of the mean central venous pressure, and it's the transducer that converts mechanical pressure into a kinetic energy that can be viewed. The transducer manifold. Well, the transducer is placed into the manifold, which is easily levelled to the phlebistatic axis. And the phlebistatic axis is the fourth intercostal space along the mid-axillary line, and it's relevant primarily for supine patients and up to about 45 degrees of the head tilt position. Now, central venous catheters typically today come as disposable kits. It's just easier. So therefore, a central venous catheter then is a thin, hollow tube that's placed into a central vein. It provides a continuous measurement of the mean central venous pressure when connected to a monitor, and it can also be used for accessing blood sampling. You can always use it for medication and fluid infusion, and this is often called a central line in the intensive care unit. The transducer tubing, well, it's approximately 48 inches in length, and it's made of non-compressible, rigid, inflexible tubing that's filled with fluid. And the tubing, being so inflexible, prevents damping and inaccurate transmission of the physiological pressure to the monitor. Then we have the monitor, and the CVP monitor is commonly used in the management of critically ill patients, and it's the monitor that displays the data which requires competent nurses to identify normal and anomalous waveforms. So when we look at transducer alignment, there are numerous positions that can be employed depending on the patient's condition. However, the most common would be supine positioning, so that therefore it's levelled to the fourth intercostal space in the mid-axillary line, And it's the transducer level with the phlebostatic axis, which we said, fourth intercostal space, mid-axillary line. Then we have another placement. If the patient now has to be on their right lateral side, then the transducer level with the phlebostatic axis is still the fourth intercostal space, but the mid-sternal line. If the patient has to be placed in the left lateral position, then the transducer level is still with the phlebostatic axis in the fourth intercostal space, but on the left sternal border. But typically it's going to be the supine position. Now, a normal CVP waveform consists of the following. You've got the A wave, and the A wave is a small positive deflection, and it represents atrial systole, which is atrial contraction. Then you have the X1 wave, which represents atrial relaxation. And the X1 is a small negative deflection when the atria relax. Then you have the C wave, which is controversial, but I'll use this explanation. This is closure of the tricuspid valve. And in the C wave, when you get closure of the tricuspid valve, you get a small positive wave as a deflection. Then you've got the X2, which a lot of people don't include. I'm including it here because I think it's relevant, that the X2 wave represents isovolumetric contraction, and this is when all the heart valves are closed and the right ventricle is trying to open the pulmonic valve. So X2 is represented by a negative wave deflection, which represents isovolumetric contraction. Then you've got the V wave, and the V wave, this is atrial diastole, when the atria fill with. So during atrial diastole, the V wave is a small positive deflection in the waveform. Then you have the Y wave, and the Y wave actually represents tricuspid valve closure. And the Y wave is a negative deflection. It's a negative deflection that represents tricuspid valve closure. So we have the ACV wave. That's typically how it's described, rather than the AC, X1, X2, V, Y. Now these are some examples of abnormal CVP waveforms, and there are many, many more. You've got underdamping, and underdamping creates a waveform with too many oscillations, and this can lead to a false high CVP or a false low CVP, and the causes can typically be the catheter really moving around in a hyperdynamic circulation, catheter whip. You've got inflexible tubing, or the catheter's in the wrong position, or there are transducer issues. Now, troubleshooting the pressure waveform, as we've mentioned previously, can be done with the square wave test. And the rationale for the square wave test with CVP lines, this test, as we've mentioned previously, is designed for you as the clinician to identify if the transducer is over or under damped. Performing the square wave test, when you pull the fast flush valve, you allow the pressure to deliver normal saline to the transducer at a pressure of 300 millimeters of mercury, which is very, very fast. And this then produces a square waveform that rises steeply as a plateau and then returns to the baseline sharply when the flush valve is released. Optimal damping after a fast flush, there should be 2 oscillations, and the height of the positive oscillation should be 1/3 or less of the previous oscillation. The cause, it's telling you the transducer is working correctly, and it provides then correct data and reading. If it's underdamped after a fast flush, there are too many oscillations. And the cause, as we mentioned previously, incorrect tubing length, too many breaks in the line with stopcocks, and this can provide wrong data and high readings. Then you can have overdamping with 1 or no oscillations. after the cessation of the flush. And the cause could be air, a clot, a kink, incorrect tubing, stopcocks breaking the line, and this provides wrong data and potentially low readings. We also have artifact, and the artifact is just interference, and this could be as a result of electrical equipment, bioengineer required, or IV fluid infusion into the same line. Then you've got catheter fling or movement. As I said, this could be as a result of a hyperdynamic circulation or with breathing. Then you've got catheter obstruction, where the catheter is actually kinked, and this could be a manual problem in relation to the neck position, or it could be the stopcock is turned in the wrong way, or there could actually be a clot or a kink. Then you've got the central venous catheter, right atrial, right ventricular catheter migration. And what you'll end up seeing is the central venous catheter has migrated through the tricuspid valve into the right ventricle, and you get a right ventricular pressure waveform. This can also cause cardiac dysrhythmias, so observation is really important. And if required, the catheter can be pulled back into the correct position in consultation with the physician in charge. Then you've got clinical anomalies that can be associated with the central venous catheter and pressure, such as complete heart block. And intermittently, you might get a cannon wave or a huge A wave because the atria are contracting against a closed tricuspid valve. But it's typically intermittent. Then you've got atrial fibrillation. And in atrial fibrillation, there's no atrial contraction. There's only fibrillation, so you won't see an A wave. You've got tricuspid valve stenosis, and there you'll see a small Y because there's atrial outflow obstruction. And you'll see a big A, which is a big inflow obstruction. You can have tricuspid regurgitation, and in this situation you'll see a big A wave and a big V wave. The problem is you've got regurgitation, which causes a big preload. Cardiac tamponade, as we mentioned in your pre-test question. Cardiac tamponade because of high diastolic filling pressures due to cardiac compression, essentially the heart being squashed. There's no Y wave because there's minimal cardiac outflow. So what are the nursing considerations? So we're looking at complications really with the central venous catheter. So you have to observe that the catheter is in the correct place, and you need to be able to read a chest x-ray. There's also a chest x-ray learn shot for those of you that are interested in observing correct catheter placement. Then you've got infection. Especially catheter-related bloodstream infections. You've got pneumothorax, potentially during insertion, but again, there could be migration. The catheters are typically quite rigid and hard. They do soften after a period of time with the warming of the body temperature. Hematoma, as a complication of now maybe puncturing the subclavian artery during insertion, or leakage from the central vein. So let's review. In your post-learn shop knowledge review, let's see what you have picked up. Which of the following pertain to a central venous catheter? They can be inserted into a subclavian vein, a jugular vein, an antecubital vein, or all of the above. The answer is all of the above. Okay, question 2. Complications associated with the CVC may include which of the following: pneumothorax, an air embolism, bloodstream infections, or all of the above? The correct answer is all of the above again. A CVP is an abbreviation that relates to which of the following: central venous pressure, it's normally 0 to 6 millimeters of mercury, provides data about blood volume, or all of the above? The correct answer is all of the above. Question 4. Components of the flush system should include which of the following: pressure bag, normal saline, sterile, a flush valve in the transducer, or all of the above? The correct answer is all of the above. Which of the following are true of transducers used for central venous pressure monitoring? They must be aligned to the phlebostatic axis. They must be zeroed every day or as required. They must be primed to remove air. All of the above are true. The correct answer is all of the above are true. Question 6. A CVP is usually synonymous with which of the following parameters? A, an arterial blood pressure, B, the left atrial pressure, C, a jugular venous pressure, D, the right atrial pressure. The correct answer is the right atrial pressure. Question 7. Overdamping of the pressure transducer usually denotes which of the following situations? A faulty transducer, a large waveform, correct data, all of the above. The correct answer is a faulty transducer. Which of the following may assist in the recognition of a cardiac tamponade? An elevated CVP, a low CVP, a fluctuating CVP, a CVP really can't assist? The correct answer is an elevated CVP. Okay, that's it for this Learn Shop. Thanks again. Now that you've completed Part 3, Central Venous Pressure Monitoring, review Part 4, which looks at the pulmonary artery catheter and pulmonary artery pressure monitoring. Again, if you think this course, Learn Shop, has been of any value to you, please recommend it to your colleagues, and I'll see you in the next session and other Learn Shops. Thanks for now. Bye. Dr. Manny.